Benyi Johnson is a public health professional with a background in health information management and community-based health promotion. He's currently completing a Master of Science in Public Health at McGill University as a MasterCard Foundation Scholar, where he focuses on health equity, program evaluation, and community-engaged research. Stefan has experience supporting research projects, conducting stakeholder engagement, and facilitating health education workshops with diverse communities. His professional interests include improving access to healthcare, translating research into practice for health policies, and addressing health disparities among underserved populations. Though his work with community organizations and healthcare institutions, he is also committed to promoting inclusive, evidence-informed approaches that empower individuals and strengthen community health systems. So I give you Mr. Stephen Benyi Johnson.
Good day, everyone. I'm Stephen. I'm Stephen Johnson, and I'll be presenting on my summer practicum project that I did with Dr. Auguste, which was looking at mapping stakeholders for the Casidic research. So just dive in. So we know cancer is a global burden, but when we look at small island developing states like those in the Caribbean, the burden is kind of well pronounced. And despite the high cancer burden in the Caribbean, efforts to control cancer remains underdeveloped. And this is because the region kind of lacks locally generated data and research to inform policies and practices. And this paucity in research publication stems from limited research capacity, lack of funds, and most importantly, lack of sustained commitment from stakeholders. So we hypothesized that the lack of commitment from stakeholders may be due to the fact that the stakeholders are not aware of ongoing research or they have not been sensitized enough to the importance of epidemiological research in shaping policies and practices. So that is why we aimed to identify key stakeholders in cancer research, map these stakeholders in the power interest matrix, and then strategies for better engagement were recommended based on stakeholders' position in the matrix. So to identify stakeholders, we define stakeholders to be individuals or groups with an interest or have the ability to directly or significantly influence the planning and development of cancer epidemiological research. And we're from one of these countries that made up the Organization of Eastern Caribbean States, except for Montserrat. And we also included development partners who indirectly have an impact on cancer research, but were not from the Organization of Eastern Caribbean States. So of the 159 stakeholders that we identified, 96 of them met the eligibility criteria and were included in the mapping. So for us to easily interpret our results, stakeholders were categorized into subgroups, and these subgroups were policymakers, implementers, civil society leaders, and then supporters. The power and interest scores for these stakeholders were determined for each of the stakeholders. And then using these scores, stakeholders were mapped into the power interest matrix and were categorized as promoters, advocates, latent, and bystanders. So of the 96 stakeholders, 31 of them were policymakers, 35 were supporters, 17 of them were implementers, and 13 of them were civil society leaders. 63% of the stakeholders were women, and majority of the stakeholders were affiliated with the Ministry of Health. And also, when we look at the distribution for the individual countries, we see that the stakeholder groups were fairly distributed for most of the countries, except for Antigua and Barbuda and Grenada and Saint Kitts and the Nevis, which had no representation of implementers. And after we mapped the stakeholders, we realized that 29% of them were latent, 28% of them were categorized as bystanders, and 23% of them were advocates, and that the remaining 20% of the stakeholders were promoters. Overall, overall average interest and power scores across all the stakeholders were well below 5 on a scale of 10. And since in the beginning we hypothesized that stakeholders may not be fully aware of ongoing epidemiological studies in the Caribbean, we kind of use this model called the precaution adoption process model, which identifies 7 stages of how an individual moves from being unaware of a situation to the point that they make a decision and then take action. So the categorization of the stakeholders in the matrix helped us to be able to like kind of fit these stakeholders onto each of the stages of the matrix, and then based on the position that they are on the model, recommended strategies were given to the research, the category research team for engagement. So for the strength of the study, we can say that this is the first stakeholder mapping study to kind of be done in the Caribbean. And also there was a fair distribution of the stakeholder subgroups, which we think was quite good. But however, there were a few limitations. One of them was a lack of qualitative data, which we think might have limited our ability to explore reasons behind stakeholders' position on the matrix. And also, it might have limited our ability to precisely fit stakeholder subgroups in the precaution adoption model. So we kind of, from these limitations, we recommend that future research should build on this foundation by incorporating qualitative data to better understand stakeholders' motivations and barriers to engagement. So to conclude, I would say the stakeholder mapping helped us to identify key stakeholders and map them in the power interest matrix, which helped us to inform better strategies for engagement, which I think is quite essential for advancing sustainable evidence-informed cancer policies and practices in Eastern Caribbean and other low and middle income countries. Thank you.
Thank you for that wonderful presentation, Stephen. Just for the record, Stephen is my master's of public health student that I supervised last year. I'm very proud of him for the work he's done. I mean, I may be very demanding, but I think I'm very proud today of the work you've done. All right, so I'm going to open up the floor to questions on this work inside and out and online. Amy Mills raised her hand, so you can go ahead.
Stefan, you indicated that St. Kitts and Nevis had no representation. Is it that there is no implementation or nothing being done based on your studies from that point of view?
I think the lack of representation from those countries is not because they are not implementing the study there, but it's because um, the pilot study for the Casidex study, first of all, like happened in Saint Lucia, where we have most of the stakeholders, like where we have most of the stakeholders. So I am thinking it was because the pilot study was done in Saint Lucia, and also mostly because all most of the research team are from Saint Lucia. They are based in Saint Lucia, so it kind of had more like, how do I say it? They had more representation from these countries compared to the ones that like maybe they've not really like had or maybe had the time to interact with some of the stakeholders there. So that was one of the recommendations that we made, that since they have like less representation from these countries, they could kind of tailor like or maybe focus their attention to these countries to kind of get more stakeholders to ensure that since the study is across these 6 islands, it should be well represented from all the categories of stakeholders that we have.
So is there like any follow-up or there is any bodies looking into representation on another scale?
I don't know if the research team is kind of looking to do more representation, like go there to see if they can have or recruit more stakeholders to like add on to the stakeholders that they already have. Because after I did the research and I presented my findings to my prof and my department, and now I'm getting the chance to present to the people who like this research matters to. So I I am assuming that the research team is doing that, I think.
Okay, thank you for your answer.
Yeah, so
Okay.
I'll just jump in here and just to clarify. I mean, it's great answers, Stefan, but just to clarify, so this work would have been derived from the Casadec study, which is a very ambitious but timely epidemiological study across the OCS member states, as you can see. We would have started what we call a planning and development phase, which included somewhat of a listening tour across the island. So before we started data collection or fine-tuning the instrument, there have been a lot of conversations, and a lot of the assessments of interest would have been done through how those persons would have reacted to the information we're giving them, and their participation in different activities would have put together. Being said, I think, I mean, I'm not the most confident of this work I've done. I've done quite a bit of research. This isn't the thing I'm the most less confident about, but because I'm not don't have a training in management science. However, I think there's a story to tell, a very compelling story to tell regarding these epidemiological studies are built in places where, based on our colonial history, shouldn't exist today because it was not set up for scientific research. As for St. Kitts, so implementers there would include clinicians, and so it's just simply just put we didn't meet the clinicians first, and these results are almost a year old now. So between then and now, of course, we're meeting more and more persons, including Dr. Grant Tate, who was here in Grenada with us. So it's an expanding and continuing conversation. So stakeholder mapping in its framework is something that's then continuously, and so we're growing our pool of stakeholders and our investigation team. Okay, so that's my response. Unfortunately, you cannot take more questions on this, but of course, you know where to find me, you know where to find Stefan now. You can get all the speakers' information on the website for the conference. We're going to move on to